All right, thank you all for joining today. My name is Bridget Sweeney, and I'm the training coordinator for the Maryland Addiction Consultation Service. It is noon, but I'm just going to get started slowly on just some housekeeping items because I know this is a really busy time. Usually this is transitional between morning patients and afternoon patients for a lot of providers and support staff. So we are just going to give it a couple more minutes for people to join. But while we do so, I am going to ask that you introduce yourself and your practice and a little bit about what you do into the chat for attendance purposes. It's also just great to see who else is in our learning community today. You may have other connections that you know of who you may relate to on this topic. As I mentioned, I am the training coordinator for the Maryland Addiction Consultation Service. I'm going to get a little bit into our services, but first I'll go over some housekeeping. As you may have noticed when you joined today, both your microphone and camera are disabled. That's just because this is a WebEx event setting since we were expecting a larger crowd. So while you will not be able to unmute or put on your camera, we do ask that you put any questions that you have throughout today's training into the chat, and I'll be sure to relay those to our presenters in between slides. You also may have noticed that today's event is being recorded. That recording will be available within 1 week on our MACS website, and it will also be emailed to you either with your credit certificate or with the slides. You will receive the slides immediately following today's presentation, and they will be sent to the email that you registered with. Even if you join today's WebEx event with a different email than what you registered with, just be sure to check that one that you registered with. To receive CME or CEU credit for today's presentation, you will have to fill out the evaluation survey. That evaluation survey will pop up immediately in a browser once you exit the WebEx event today. If for whatever reason that survey does not pop up, or you accidentally exit out of it, or your computer shuts down, you will be sent a link to a Qualtrics survey to complete that survey separately. Once you have completed it, please give us 1 to 2 business days to process your attendance, and then you should receive it once again to the email that you registered with. I see that a lot more people have joined, so I am just going to ask that you continue to introduce yourself in the chat. And I am going to give a brief introduction to our speakers today, but first I just want to check in. Dr. Gandhi, are you doing okay with connecting? It looks like you are muted.
Okay. Yeah.
There we
All
go.
right. Yeah. I'm good.
Okay, great. If you have any issues, let me see if I'll give you permission to share your screen.
Okay.
Feel free to take your time in doing that. I am just going to go over our MAC services and introduce you and Dr. Greenblatt. So the Maryland Addiction Consultation Service is a service that is funded by the state of Maryland and the Behavioral Health Association. So since we are funded, all of our services are 100% completely free. And we're here to provide support to prescribers and their practices in addressing the needs of their patients with substance use disorders and chronic pain management. Those services include a phone consultation for clinical questions, and those clinical questions can be as patient-specific as you'd like, as long as it's de-identified, or they can be broader on general prescribing policies or other addiction questions. So it's really up to you, but we are here to help with our warn line. We also offer education and training opportunities related to substance use disorders and chronic pain management. So similarly to today, a lot of our webinars are 1 hour long and take place during the lunch break for your convenience. But we also offer longer trainings like waiver trainings so you can get waivered to prescribe buprenorphine. We offer assistance with addiction and behavioral health resources and referrals. We offer technical assistance to practices implementing or expanding office-based addiction treatment services. So that can also range from sending you resources, visiting your practice to help answer any questions directly with providers, or even specific in-house trainings for any topics that you think your team needs more training on. Another addition that has joined the MACS services within the past year or two are our MACS Tele-Echo clinics. And this is collaborative medical education through didactic presentations and case-based learning. So how this works is once a month, you meet with a a group of other members in the medical community, and someone in the medical community brings their own case from their own patient load, and they present on questions that they have in best treating this patient with substance use related disorders. And then not only do you hear advice from other members of the medical community, but there are also several Max consultants, including Dr. Gandhi, on that training, who also help provide insight and present didactic presentations. And those also offer continuing education credits. So I'll put more information about that into the chat in 1 second. But first, I do just want to quickly introduce our presenters today. So our main presenter today is going to be Dr. Devang Gandhi, and Dr. Gandhi is board certified adult psychiatrist. He has additional board certifications in addiction psychiatry and addiction medicine. His areas of clinical, educational, and research focus include co-occurring psychiatric and substance use disorders, opioid and alcohol use disorders, pharmacological therapies for substance use disorders, and integrated pharmacotherapy of substance use disorders with psychopharmacology. So if you were to call our warm line, Dr. Gandhi is a great example of someone that you would be able to get in touch with to get some more clinical expertise. Our other presenter that will be joining in a little bit is Dr. Aaron Greenblatt, and Dr. Aaron Greenblatt is an assistant professor at the University of Maryland Medical Center. He's been a faculty member at the University of Maryland School of Medicine since completing his fellowship in addiction medicine in 2015. He divides his clinical responsibilities between the Division of Addiction Research and Treatment in the Department of Psychiatry and the Department of Family and Community Medicine. He is also the medical director of UMMC Addiction Treatment Programs at 1001 West Pratt Street, and he treats patients, coordinates clinical care, hosts research projects, and participates in clinical education of medical students, psych students, and addiction fellows. Needless to say, you are in great hands with both of our presenters today. I am going to hand it over to Dr. Gandhi to get us started. And to those of you who may have just joined, please feel free to take this time to introduce yourself in the chat. But thank you so much for presenting today, Dr. Gandhi. Let me know if there's anything I can help with.
You're welcome. Thank you, Bridget. Let me pull up my screen. Can you see it?
Yeah, so right now we're seeing the whole, I think you're sharing your entire desktop screen. I don't know if that's something that you want to do in case notifications pop
Okay,
up.
yeah. Let me see if I can change this to.
Okay,
How about this?
that looks great. As long as that works
Okay.
for you, that definitely works for us.
All right. So thanks everyone for joining us. We're going to talk about a topic that has gained a lot of attention recently, and that is microdosing. So the term I'm using is low dose initiation of buprenorphine, and I'll explain a little bit about that as to why that is so. Bridget already told you about the Maryland Addiction Consultation Service. These are the learning objectives for today's talk. And I'll start this out, and then Dr. Greenblatt will pick it up from me with a case that he recently saw. So the main objectives are to learn about the challenges of initiating buprenorphine in patients who use opioids with a long duration of action, such as fentanyl or methadone. The other is the pharmacological rationale and the differences between conventional as well as conventional versus the low dose buprenorphine initiation. And then we'll talk about some of the protocols that people have used for microdosing. If we have time at the end, I may share a couple of things about macrodosing, which is the opposite approach. And the reason for doing that would be that there were a number of questions about that in the sign up that people at the time of signing up. So I thought if we have time, we'll get to that. So the terminology for this is a little bit in flux. Microdosing and microinduction are probably the most commonly applied terms, and they serve a practical purpose. I mean, they're easy to use, but they are a little bit misleading and can be a little confusing. And this has become more of an issue because another topic that is gaining a lot of attention recently is the use of psychedelics, like psilocybin mushrooms, for example. And the term microdosing is also applied to the use of those in very tiny doses for mental health issues, as well as for some addictions. Now, this is all very experimental, very early, but I suspect that we're probably going to hear a lot more about the psychedelics in the years to come. So the term microdosing in our context may be a little bit confusing. The other term that is used is the Berne's method. This is the older term that was used by the people who first published their protocol for a low-dose buprenorphine initiation in 2010. This was a group from Bern, Switzerland, and they called their method the Berne's method. And that is why that term originally took off. What's happened since is that there are so many different variations on their protocol that are now in use. So really, I mean, what people are doing is no longer the Berne's method. They're using their own version of the method. The third term that has been used is rapid microdosing. And this typically has been applied to shorter initiation protocols of 1 to 5 days. The original protocol was somewhat longer than that. So the shorter versions of initiation protocols have been called rapid microdosing. The term that is gaining some degree of traction now is low-dose buprenorphine initiation. And that's the term I'll be using as far as possible. And this is favored because it's a general term and that captures the wide variety of protocols that people are using. So what's the need for low-dose buprenorphine initiation? So we've always known that initiating buprenorphine is a little bit challenging, and that is because of the risk of precipitated withdrawal. Buprenorphine otherwise is extremely safe, and the precipitated withdrawal is also not life-threatening, but it's very uncomfortable, and that often kind of causes a challenge at the start, causing some patients to even drop out of treatment. This has become this is true much more so when transitioning from a full mu opioid receptor agonist with prolonged action. So compounds like methadone or fentanyl are much more difficult to deal with. It was rarely a problem when heroin was the main drug that people were using, but it's become much more difficult to start people on buprenorphine since fentanyl has appeared on the street. And now, as you may well know, fentanyl is pretty much what people are using. There is some heroin, but really the vast majority of the patients are either using just fentanyl or a mixture of fentanyl with other opioids. So this has kind of become an issue in routine clinical practice now. Precipitated withdrawal occurs because of buprenorphine's peculiar pharmacological property. And that is the two things, one is the low intrinsic activity, which is what we know as partial agonism or partial agonist action at the mu opioid receptor. And that combined with its capacity to displace full agonists from the mu receptor. And that is what we recognize as its high affinity for the mu receptor. So buprenorphine is not able to activate the mu receptors fully, but at the same time, it has a very high affinity for the mu receptor. It's higher than that of most full agonists. So it's going to kick off the full agonists that might be on the receptor, and then can't activate the receptors fully. So there's a drop in receptor activity, which we see as precipitated withdrawal. So this slide basically shows how that works, when there's nothing on the mu receptors, or if there's an antagonist on the mu receptor. And if you give somebody buprenorphine, there is really not much of an issue. But when there is a full agonist on the mu receptor and you give buprenorphine, it will displace the full agonist and then can't activate the receptor fully. So there's a net drop in receptor activation, and that is what causes the precipitated withdrawal. Keep in mind, the naloxone, there's a common misperception that the naloxone and Suboxone, the combination product, causes precipitated withdrawal. That's not the case. It's buprenorphine itself that causes this problem. A quick word about some basic fentanyl pharmacology, because that is what is also underlying the problems that we're facing now. So fentanyl also has some peculiarities and a rather distinct pharmacological profile compared to other opioids. So first of all, it has a very high potency. It's about 100 times more potent than morphine, about 50 times more potent than heroin. It crosses the blood-brain barrier very quickly, and it has a very high degree of lipophilicity, which means that it gets sequestered in the fat tissue in the body, and then some of it makes it back, is gradually released from there. So that makes for a long, very extended elimination half-life of fentanyl. So it sticks around, it stays around in your system, although its half-life as such is not that long. It does stay in your system for a much longer time because of this the uptake in the fat tissue and then release from there. So that extends the window of risk for precipitated withdrawals. As long as fentanyl is sitting around in the person's system, there is some risk of precipitated withdrawal. There's an interesting study. The graph on the right side refers to a study that was done by the folks at Hopkins a couple of years ago, and that shows how fentanyl is eliminated from the body. And what they did was that they regularly drug tested people who were in a residential rehab, and just to see that once people stop using fentanyl, how long does the drug test come up positive? And what they found was that the mean time for elimination for fentanyl and norfentanyl to clear was 7.3 days, so about a week for fentanyl and about 2 weeks for norfentanyl, which is a metabolite. It's an inactive metabolite of fentanyl. And in one participant, they continued to test positive for fentanyl for 19 days and norfentanyl for 26 days. This is important because we've seen this in our clinical practice too, that patients often tell us that they're not using anything and they still keep coming positive for fentanyl for a little while. So this is probably why that is so. The other thing that makes fentanyl much more of a dangerous opioid is how it acts on the mu receptors. So there is the standard, there are two pathways of action on mu receptors that opioids, that's how the opioids act on the receptor. The first is the standard G protein coupled pathway. And that is responsible for analgesia and many of the other actions of opioids on the mu receptors. Um, there's a second pathway that's called the beta-arrestin pathway, and fentanyl has a strong action on that. And that is thought to be responsible for respiratory depression. So respiratory depression is much more of a problem with fentanyl than with the other opioids that people were using before. And that's why that could be why we are seeing so many more overdose deaths. Fentanyl also causes some rigidity of the chest wall, which makes breathing more difficult, and that could also be adding to the risk from fentanyl. So the net effect of all this is that there's more fentanyl on the street. It's way more dangerous. There's a great imperative to put people on medications for opioid use disorder because of that. However, it's become much more difficult to do so, especially with buprenorphine. So when precipitated withdrawal occurs, the existing guidelines basically tell us how to deal with that, and that they refer primarily to the switch from methadone to buprenorphine, which people sometimes do, but it wasn't that common an event. So, and the guidance basically is that if somebody is on methadone, you taper down the methadone dose to below 30 milligram, and then discontinue it for 1 or 2 days, and then start with buprenorphine at a low dose, typically about 2 milligram sublingually. Even following these guidelines, we see cases where there's precipitated withdrawal. I had a patient who had precipitated withdrawal, although she was on 9 milligram. I had another patient who was on 20 milligram as his regular dose and still had precipitated withdrawal with a small dose of buprenorphine. So this was a problem. I mean, this guideline was useful, but not always, didn't always work. Now, as I mentioned before, this has become much more of a problem of routine clinical practice since fentanyl appeared on the street. And we all are now seeing way more instances of precipitated withdrawal. The typical way we have kind of dealt with precipitated withdrawal is by tapering and stopping the long-acting opioid first. With methadone, as I said, you taper it down to below 30 milligram and then give a couple of days of methadone before starting buprenorphine. With fentanyl, we typically tell the patients not to use for about a day or so and come back to the clinic in withdrawal. However, again, with that, it doesn't always work out. We've also been we've also tried to extend the interval between the last opioid use and the first buprenorphine dose. We are waiting to start buprenorphine until the patient has a greater intensity of withdrawal, which means a higher COW score. And when it does occur, we manage precipitated withdrawal using symptom-based treatment. That is the supplemental medications like clonidine, ibuprofen, loperamide, bentyl, those kinds of medicines dealing with the symptoms of precipitated withdrawal. All of these have the risk of extended withdrawal. Some patients will drop out of treatment and refuse buprenorphine going forward. Some of them will just relapse, and some may even overdose. So there are significant risks associated with having precipitated withdrawal. So low-dose buprenorphine initiation was thought of as an alternative way to reduce the risk of precipitated withdrawal by initiating buprenorphine using really small micro doses without first tapering or stopping the full agonist opioid. So this is the definition of low-dose initiation or microdosing from this article that's cited below. That it's a novel approach that by harnessing buprenorphine's unique pharmacological profile may allow for circumventing the need for prolonged opioid tapers and reduce the risk of precipitated withdrawal. which nicely captures the whole concept. In contrast to traditional initiation, patients may continue their use of full opioid agonists, for example, methadone or fentanyl. So we don't actually, we tell them not to stop using methadone or fentanyl when we start them on buprenorphine. And I'll explain, we'll look at some protocols afterwards. Until the patient reaches a therapeutic dose of buprenorphine. And at that point, the full agonist is either is just discontinued without the need for a slow taper. Then typically this process plays out over a 3 to 10-day period. So this is how the conventional versus the low dose process works out. The first step in the conventional process is stopping the full buprenorphine agonist, while with low dose initiation, that's the last thing you do. And essentially, this just illustrates how the process plays out. There's a gradual increase in the dose of buprenorphine over several days. The full agonist may either be gradually diminishing over this time, or the person may continue to use the full agonist at the usual doses and then just discontinue at a certain point where buprenorphine is at the therapeutic dose level. The Bernice method, this case report was published in 2010 in German. And then they published that original case plus another case in an English language publication. And they called that the Bernice method. They based their protocol on some clinical observations. First of all, they had noticed that about half of their buprenorphine maintained patients were concomitantly using full mu receptor opioid agonists. This use was not associated with opioid withdrawal. They also were aware of the repetitive administration of mu receptor antagonist, naloxone, as Narcan, that it quickly leads to a maximum of withdrawal symptoms, and then they decline despite continuing naloxone application. So this method was used in the 1980s for several rapid opioid withdrawal protocols. And then they saw that a very small dose of buprenorphine at something like 0.2 milligram intravenously did not produce opioid withdrawal in individuals receiving methadone maintenance. So they based their protocol on these observations. And the hypotheses were that repetitive administration of very small buprenorphine doses with sufficient dosing intervals of about 12 hours would not precipitate opioid withdrawal. Because buprenorphine has very long receptor binding time, buprenorphine will gradually accumulate at the receptors. So it will go and stick to the receptors and then sit there for a long time. So gradually the buprenorphine will kind of replace the full agonist at the mu receptor little by little. The original Bernice case was a patient who experienced prolonged withdrawal using the conventional approach for induction, she was actually using heroin, not fentanyl. She was then started on a small dose, 2.2 milligrams sublingual of buprenorphine with overlapping heroin use, and then the dose was gradually increased until the patient reached a maintenance dose. And later, this patient also switched from buprenorphine to naltrexone using a similar approach, starting with really small doses of naltrexone, going up to a maintenance dose. So this was their protocol, 0.2 milligram initially. The patient continued to use about 2.5 grams of heroin on day one, 0.2. On day two, she used a little less heroin. Day three, it was 0.8 milligram plus a second dose of 2 milligram. heroin use came down to 0.5 grams. Day 4, 2, and 2.5, and so on, until the patient on day 9 reached 8 plus 4 milligrams, a total of 12 milligram of buprenorphine. And she had stopped using street heroin by day 5, or day 6. This is one more low-dose initiation protocol that uses a slightly different method. One thing I want to point out is that there are as many protocols as publications. There are a lot of different protocols that people have used, which kind of begs the question as to whether the actual protocol matters all that much. The basic idea that you start really low and then gradually build up the dose over several days, that still holds. But I don't know whether it would make that much of a difference whether you start at 0.2 or 0.5 milligram daily. So this was starting at 0.5 milligram. 0.5 BID on day 2, 1 milligram BID on day 3, and then going up to 4 milligram TID. So again, 12 milligram on day 6. It's a little bit faster. This is yet another protocol where the starting dose was 0.25 milligram on day 1, and then gradually going up to 12 milligram by day 7. So at this point, I would hand over to Dr. Greenblatt, unless Dr. Merritt is with us and she can explain this slide.
I don't see Dr. Merritt either in the panelists or attendees. I think she might be joining a little bit later.
All right, thanks, Dr. Gandhi. So yeah, this is just to continue what the direction Dr. Gandhi was going. This is yet another protocol for a way to, as the other slide said. And by the way, I'm Aaron Greenblatt, also here at University of Maryland. Sorry, I was a couple minutes late today. Another protocol kind of directed at the same idea of using gradually increasing levels of buprenorphine to kind of sneak the buprenorphine onto the mu receptor and avoid, as Dr. Gandhi said, the catastrophic effects of precipitated withdrawal. This is from a 2020 case series using the Butrans patch. I think this was actually initially published by Howard Kornfeld and Heidi Reitz, I think in the mid-2010s or early 2010s, to describe transitioning people from prescription opioid analgesics, including methadone, onto sublingual buprenorphine for treatment of pain. But the basic idea is the same. The nice thing about the Butrans patch is that it has a very slow onset of action and also comes in low doses. So those two things would lend it nicely to this transition. Right now, Butrans patch costs about $100 per patch, per 7-day patch. And also it is not an approved, even though it is buprenorphine, it's not FDA approved for treatment of opioid use disorder. So unfortunately, although this approach is very pharmacologically appealing, it's not yet legal to do this in an addiction treatment setting. We can imagine situations where a patient with comorbid pain and addiction and some good insurance, would be a reasonable person to try this with. Next slide, please. We actually, some colleagues and I wrote to the DEA to say, well, under 21 CFR 1306.07b, that's the so-called 3-day rule, a physician may administer up to 3 days of agonist treatment while arranging for one day at a time, but may do that for up to 3 days while arranging for definitive addiction treatment. We propose to use the Butrans patch under this 3-day rule. And this was our response letter from the DEA. It's probably small on people's screen, but in summary, we aren't gonna say that you can't do it, nor are we gonna say you can do it. But if you do it, we will be there to make your life a lot harder. Unfortunately, they just ignored the question, but they did encourage us to submit comments for public consideration. Next slide, please. I want to talk about a local case that we had here, and I'll try to be brief because I think that probably we have lots of people who have questions of their own and desire to participate, and so we certainly want to make room for that. But I will say that as Dr. Gandhi pointed out, there's as many protocols as papers, and I can share one experience that I had here. I've done this with a few people, and what I would say is that actually there probably are as many protocols as there are patients, not just papers. Because in my experience, even if you spend a lot of time explaining to someone how to use the buprenorphine for this low dose initiation in an uncontrolled non-hospital and non-residential treatment setting, people end up taking the medication sometimes in ways that you did not advise or predict. So this is one example of this. My patient GB, 65, kind of an old 65 with chronic back pain and hip pain from osteoarthritis. He's had lung cancer in the past. He's still smoking. He was on methadone, but his attendance at the clinic, even when we had extra COVID take-homes, was really hindered by his mobility problems, pain, and I'd say also uncontrolled addiction. Toxicology was positive for methadone, opiates, fentanyl, benzodiazepines, sometimes cocaine. He's come back early, having taken extra methadone or missing some of his take-home bottles. So not reassuring for like extra medical take-home bottles. And we have a possibility of using an app to remotely monitor people taking their medication. He did that briefly, but kind of petered out and I think then lost his phone. So that didn't work either. Next slide, please. So he came, he had gotten a week of take-homes. He came back having missed a day, and he was interested. You know, we were talking about Sublocade, or extended release injectable buprenorphine. Just kind of, he was in a state of perpetual getting back on methadone, being in withdrawal, relapsing to opioids. And he said, yeah, that sounds really good, something that I don't have to think about taking this. And I said, well, let's try doing something kind of traditional. I'll dispense a 1-week taper, and then you'll come back in a week to start the bup. And I gave him some comfort medications. I think looking back at the chart, in this case, I chose some clonidine, cyclobenzaprine, loperamide, ondansetron, and trazodone, and gave him a dispensed taper for him to come back in a week to talk about getting onto buprenorphine. I noticed I put that last dose of 5 milligrams in there really as a placekeeper, just to keep him occupied during that last day before returning to treatment. He didn't come back. He came back a month later. He was still interested in the buprenorphine injection. I represcribed those comfort medications, and in that interval, 1-month interval, one of my fellows, Dr. Will Hall, had shared somebody's handout. I don't know where this handout came from, but it's a handout that described the rationale of low-dose buprenorphine induction, and also had a graphic. You just can see the morning dose here, but a graphic that was based on the Robbins, one of these protocols, one of these published buprenorphine initiation protocols. I spent about 25 minutes looking at this with him and describing how to use it. We dispensed some 2 milligram films from my opioid treatment program here, and so he went home with enough 2 milligram films to kind of start this to get through day 6, actually. And I followed up with him the next day, and he had reported precipitated withdrawal with that initial 0.5 milligram dose, which was 24 hours after his last self-reported opioid, and he had continued to use fentanyl. So it didn't quite work as well as I had liked, or as I was hoping, or as that he was hoping. Next slide, please. A couple weeks later, we had another opportunity to try. He got a prescription for some Percocet from his primary care doctor's office. I encouraged him to use this instead of fentanyl as a bridge off of extramedical opioids. He took some of the Percocets. He just still felt compelled to take some extra fentanyl as well, because by his account, his stomach had started to cramp up. I really said, please use the oxycodone instead. Let's give this fentanyl as long a chance as possible to get out of your system. And then use your remaining 2 milligram films to get back onto buprenorphine. Followed up by phone and text the next day. He hadn't yet started buprenorphine, but he expressed some appreciation for the follow-up and some guarded optimism. And then he was lost to follow-up again. But while making these slides, I called him yesterday, and he said, actually, I've been taking a 0.5 milligram about every other day, and I'm going to be running out of the Suboxone tomorrow. And he said he's cut down on his buprenorphine use, but he's now taking a pill of dope. He's gone down to a pill of dope a day, in addition to about a quarter of a film every other day or so. So I think just to say that he is still trying. Maybe this is going to work, but it doesn't always work in the way that you would hope based on the published case series at this point. Go ahead. So there is an evidence base that kind of Dr. Gandhi has already reviewed, and as Dr. Gandhi kind of reviewed also that there are a wide variety of protocols. What I would say is that one interesting thing about the Butrans patch is that actually the Butrans patch that was used in the European initiation studies, in Europe, the Butrans patch comes in a higher dose, 35 micrograms per hour. But I suppose if we are allowed to use it, we could approximate that. Next slide, please.
Dr. Greenblatt, I'm sorry to interrupt, but we do have 2 questions about Butrans that you may have touched on.
Oh.
Dr. Salwan asked, is the Butrans patch method legal in the hospital setting?
So the Butrans patch method would be legal in a hospital setting if the person was admitted for like a medical concern, a medical or psychiatric concern, because physicians can use whatever opioid they want to treat opioid withdrawal for patients that have been hospital, that's to say, as treatment, opioid withdrawal treatment incidental to the indication for which the patient has been admitted.
Okay, great. And this is pretty similar. Are there regulations around using Butrans in an OTP setting as part of an induction strategy for buprenorphine?
Yeah, so that's what I had asked the DEA for permission for, and Dr. Salwan also said, would this be allowed in the ED for 72 hours? So here's the issue. The regulations, the 3-day rule says that you could use any opioid to treat opioid withdrawal symptoms if you are a physician administering that medication, no more than a 1-day supply for up to 3 days while arranging for definitive opioid use disorder treatment. The issue is that the Butrans patch is something that you stick on, and then it releases medication. It's designed to release medication for 7 days. So it doesn't really fit into the existing regulations. And I asked, well, the question I'd asked the DEA that I didn't get an answer for is if I stick this Butrans patch onto a patient on day 1, I've certainly administered a 1-day supply of an opioid, a non-approved opioid for treatment of opioid withdrawal that day. But day 2 or 3, what I've technically done is I've just administered a 7-day supply of opioids to an individual, with the hope that that's going to help them bridge to definitive opioid addiction treatment. And that is not in adherence with the current regulations. I was hoping the DEA would say, yeah, just take it off after 3 days. And technologically, it's only allowing you to administer 1 day at a time, but they did not answer in the way that I was hoping they would. And yeah, Dr. Salwan says the DEA sees this as a 7-day dispense. They did not say that they did not see it as a 7-day dispense. It was unhelpful, and they said, if you have any other questions, reach back out, and I did, and they didn't respond to me. If anyone knows that anyone helpful at the DEA that would like to re-engage with this question, I would be happy to collaborate with you. There have been some systematic reviews of the total number, the whole body of case reports and series. Again, to reiterate, the regimens ranged fairly widely. All of the patients in these case series achieved a maintenance dose of buprenorphine, whether they were transitioning from extramedical opioids, fentanyl, prescription analgesics, or methadone. It's fine. I think we went backwards. Forwards, please. And according to these case series, precipitated withdrawal occurred in only 3 out of 57 patients. Median buprenorphine starting dose was low, 0.4 milligrams, and they took about a week to make it happen by going up about 1 milligram a day. Among studies not reporting precipitated withdrawal, it seemed that 0.5 milligrams should be okay. Although, as I said, in my one patient's experience, that was actually surprisingly, to me, challenging for them. People who, there was still some precipitated withdrawal in individuals, even those who were transitioning from a low dose of methadone. One thing that I would say is a couple of things. First of all, when I see numbers like this in case series, it just makes me worry about selection bias in the literature. Just because it worked so well. Like, I really want it to work this well for my patients, but it just hasn't. So I just think that we can keep that in mind when we're explaining this to patients and encouraging them. And then what else was I going to say? That should be fine. And basically, there's lots of protocols, and we should be flexible. Keep the general concept in mind because it seems like a very, very useful one. But we don't have to, there's probably no harm in stretching it out or moving faster if a patient is tolerating those initial doses. Buprenorphine, obviously, other than the risk of precipitated withdrawal, is incredibly safe. And so if someone tolerates 2 milligrams or 4 milligrams, it's probably fine to titrate them fairly rapidly if they're continuing to complain of withdrawal symptoms to a higher dose. Oh, the one other thing I was going to say is that, both methadone and fentanyl, because of their long half-lives, seem to have a protracted withdrawal period. And so it can be really confusing to know, as with any buprenorphine initiation situation, it can be really confusing to know if the withdrawal symptoms that people are complaining about are the result of buprenorphine or just continue to be the withdrawal symptoms from their previous opioid that is kind of increasingly emerging as the time from their last use is increasing. And so, that would be the kind of thing that you could explain in patient-centered terms to encourage someone and keep someone optimistic and on track, and just encouraging use of those adjunctive comfort medications. The one other question that Dr. Salwan asked, which is very good, how did GB get some of this oxycodone? And the indication would be pain, exactly. That was kind of on the edge, but the person's PCP knew that what he was trying to do with buprenorphine and could justify that prescription because he was having some pain. But yeah, in general, we're unfortunately not allowed to use opioid analgesics that are not approved for treatment of opioid use disorder as a kind of bridge from extramedical opioids to buprenorphine. I wish it was. Next slide, please. Devang, do you want to take the conclusion and then?
Okay, so in conclusion, it's a potentially useful approach. We don't have anything better to prevent precipitated withdrawal at this time. So I think this is certainly something that looks promising. It may eliminate the need for prolonged tapers or a long period of abstinence before starting buprenorphine. It may prevent dropouts, relapses, overdoses. The thing to remember is that although it has gained a lot of attention and is being applied very widely, the evidence for its effectiveness is still very preliminary. It's low quality, and it's limited to case reports. As Aaron mentioned, there might be a publication bias. People probably publish the more successful cases rather than the failures. So it's entirely possible that when we start using it widely, we may have as many failures as successes. And then there's the need for high quality randomized controlled trials. There's one underway in Canada, but the results are probably not going to come out until 2025. So that's going to be a long wait for that. And then more low dose initiation friendly buprenorphine formulations. Right now, the lowest is 2 milligram. So you're forced to cut the film or the tablet into a quarter, which is not that easy. So hopefully some manufacturer will come forward and start making lower doses that we could use. Compounding pharmacies are one more option that people could use. But
sorry to interrupt. I will say that there is a Zubsolv 0.7 milligram tablet that's available. And so Zubsolv, as people probably know, if you try to cut it, you can't cut it too much. Unfortunately, not as easy to cut as the films, but you certainly could cut it down to a 0.5 milligram equivalent. So a 0.35 milligrams of Zubsolv. And it probably is not totally bioequivalent to 0.5. So it might be something that people could consider.
Okay, so that's where we will stop. As I said, if we have time, I can tell you a little bit about the high dose initiation, but that is somewhat different. It's not meant for switching from buprenorphine, from fentanyl or methadone to buprenorphine. So, but we can answer questions if you have some.
I think that's the only question that we do have. They just asked, can you share a little bit about macrodosing?
Okay, all right. So, so that's the term which we could call high dose buprenorphine initiation. And that has been generating some interest. It's based on a large uncontrolled case series that was published in JAMA, I believe last year. And then there are a few case reports of high dose buprenorphine initiation. It's unclear if this would work well in the presence of fentanyl or methadone. The reason they conducted this trial of high dose initiation in an emergency room in California was based on patients' inability to fill discharge prescriptions in a timely manner. So they basically were starting people in the ER on buprenorphine, but then the patient would not be able to fill the prescription immediately, and then there would be a gap. So they basically, their thinking was that if we start them on a really high dose, even if it takes a little bit longer for the prescription to fill, as I mentioned before, buprenorphine stays on the receptors for a long time. So people would not go into withdrawal right away, and then they would have some time to fill the prescription and or start going to a clinic. So that was the rationale for the high dose buprenorphine initiation in that particular study. Then this was the study that I was referring to. This was published in 2021. And the first author is Herring. It's in JAMA Network Open, so you can actually pull it up. It's on PubMed Central, and you can easily download that. And they found that this approach worked quite well. It was a fairly large study, and it was done over the whole year, calendar year of 2018. And the starting dose was 12 milligram or above. Keep in mind that this was not a randomized trial. It was retrospective chart review. So they had a protocol, but the data collection was not very systematic, and they looked at the charts and extracted data from that. This was also based on a single emergency room in Oakland area in California. So, generalizing it to other settings is problematic. ED, again, ED is much better placed if there was any problem with the high dose to deal with it. So that was another safety feature that most clinics won't have. Again, they didn't have many complications or problems at all. Things actually worked out pretty well, and respiratory withdrawal was quite rare in less than 1% of the cases. And that actually did not correlate with the doses that those patients received. So overall, it looks like this was pretty safe, and it worked quite well. Unfortunately, there were many exclusions. So recent methadone use, for example, was an exclusion. So the sample was not necessarily, again, less generalizable than one would wish for. There's no information given about which opioids the patients were using. And this, I think, in my mind, is a big issue because we don't know if people were using fentanyl or heroin. If it was heroin and you give them any dose of buprenorphine, I think they would probably do fine. If it was fentanyl, I don't know whether there'll be more cases of respiratory withdrawal. My guess is that there probably was enough fentanyl around in the area at that time, but we don't know. And their panel in the supplemental data that they provided does not seem to have included fentanyl. So I'm not sure if they were even looking for fentanyl use in these patients. And we don't know what the prevalence of fentanyl use in the area was at that time. So again, it's kind of hard to extrapolate to our area where fentanyl seems to be the main substance on the street. So those are some of the drawbacks in this study, some of the limitations which make it difficult to kind of draw much of a conclusion from this. The evidence is still very low, and it may be a good approach for patients who cannot connect to a clinic right away. And it may be a good approach for use in emergency rooms, but I am not sure if it's something that one would use in a regular clinic setting at this point, at least. Right?
Great. Thank you both for presenting today. Obviously, this was a great discussion. We do have 2 questions right now. This one we got more recently, but I do want to ask it because I think the answer might be a little more straightforward than the other question, but this is for Dr. Greenblatt. There was mention earlier of not being able to use an opioid agonist for a bridge. Do you know where to find the regulations stating that?
So you can use an opioid agonist for a bridge as a physician if you are administering a full agonist for treatment of withdrawal symptoms while bridging to full treatment. So that would be a situation in which you have your clinic stock of whatever opioid you want in your office. You could actually have the patient come in and you could administer them 1 day supply at a time. The regulation, so prior to the passage of Data 2000, the only time that you could prescribe an opioid for treatment of opioid use disorder was in the context of a federally licensed opioid treatment program or a methadone program. Data 2000, I think that's probably precisely where it says that. We can look it up, but Data 2000, which is the language of Data 2000, which is the act that legalized the use of buprenorphine products, is that you actually can prescribe a Schedule 3 or higher opioid that is FDA approved for treatment of opioid use disorder from an office setting. Devang, do you have the regulations that say we're not allowed to prescribe opioids for treatment of opioid use disorder? Because that's essentially what you'd be doing.
Unless it is approved for that purpose, which buprenorphine is, but other opioids are not.
Dr. Salwan helpfully includes the point that it's actually the Harrison Narcotics Act of 1914. It's like so baked into the medical culture, but yeah, it's the Harrison Narcotics Act is what said we're not allowed to use opioids for treatment of opioid use disorder. And so it was only in the 1970s, after Dole and Neiswander piloted the use of methadone that actually the Harrison Narcotics Act was amended or superseded to allow for the use of methadone in the context of an OTP.
Great, thank you. We do have a couple more questions that have trickled in. This one is kind of a long one. So please let me know if you'd rather follow up with this person directly. But the question is, does long-term use of full-dose buprenorphine prevent the euphoric effects of extramedical opioid doses? And does it long-term use of full-dose buprenorphine also prevent withdrawal symptoms when the patient experiments with recreational extramedical opioids?
So yes, so when somebody is on an adequate dose of buprenorphine or methadone, we expect that any extraneous opioids would not produce much of a euphoric effect. And sorry, what was the second part of that question?
The second part was, does long-term use of full-dose buprenorphine also prevent withdrawal symptoms when the patient experiments with recreational extramedical opioids?
So if people are using other opioids, generally, and many of our patients are, as I mentioned, the original Bernie's group, they also base their hypothesis on the fact that their patients were using extraneous opioids and not having much of the withdrawal. So the issue that, though, is that I suppose one could theoretically use a lot of a very high dose of opioids and maybe get some effect from it, even if they are on good doses of buprenorphine or methadone. I mean, we're seeing people continuing to use, and we've seen that much more often with fentanyl, that people seem to still get a high, even if they are on a fairly high dose of buprenorphine or methadone.
Great, thank you. We do have one. Go ahead, Dr. Greenblatt.
No, I was just going to say, I in the pre-fentanyl era, I feel like we could count on the phenomenon of an opioid blockade. In the case of methadone, from what was called agonist blockade, maybe related to internalization of the mu receptor. And in the case of buprenorphine, because buprenorphine would essentially outcompete the heroin at the mu receptor. As I think, as Dr. Gandhi was saying, now that we have these very, very high affinity, high potency opioids that have entered the drug supply, I feel less confident that we can count on that blockade effect. But certainly the withdrawal management and craving management effects of the medications persist. And that, if you think about it, those are the most important features of both methadone and buprenorphine. Because if you're not testing the blockade, then it doesn't matter if you have one or not.
Thank you. I know you. Oh, Dr. Gandhi, were you about to say something?
No.
Okay. I know you both are really busy, but we do have one more question. If you'd rather follow up with this person directly, let me know. But they say, I serve in a correctional facility that is also an intake center. What do you recommend for induction strategy in light of the limited resources within a jail? And they are classified as an OTP.
So I'm assuming you're using buprenorphine, or is it methadone that you're starting people on? Can the person unmute and just explain that?
Carolyn said that they have both. Carolyn, I am going to give you privileges to unmute.
Oh, great. Thank you.
There you go. You should be able to talk now.
Thank you. So historically, we've been able to use methadone. So the OTP has been operational for about 5 years. We use methadone continuation, and we use, for people in withdrawal from opioids, we use a methadone-based 10-day taper. Because of House Bill 116, we are very soon going to be able to do buprenorphine continuation and buprenorphine induction. So the next phase is buprenorphine continuation. So probably 6 months from now, when we're starting to perform buprenorphine inductions, we'll get into the kind of that space. Okay, how are we going to go about doing this? I would like to avoid having patients wait 3 days, 2-3 days, and manage them with comfort medications when they don't have access to anything else. And then Yeah, so just looking for advice, any tips that you think might be helpful.
So in general, starting methadone is not really a problem,
Right.
yet. So because that is not going to cause precipitated withdrawal. The issue will come when you begin to start people on buprenorphine. And then I suppose you'll have to think about, how much withdrawal the patient is in, what the patient might have been using before they come in to your facility, and when was the last time they used anything. So based on those things, I would suggest, you probably want to start them on a small dose of buprenorphine. Just this morning, for example, we started a patient in our program on buprenorphine, and we had some concerns about whether the patient will tolerate or what dose to start the patient on. So we started with 1 milligram, half a tablet initially. And the patient had a COW score of about 7 or 8. And he tolerated 1 milligram quite well. So then we could give a 2nd milligram dose after an hour or two, and then give him a couple milligram in the evening as a second dose. So by the end of the first day, and hopefully the patient will be on 4 milligram. So the basic principle is that maybe you want to start with a smaller dose if you're not sure about the patient's ability to tolerate a higher initial dose of buprenorphine, and you're worried about precipitated withdrawal. Does that answer your question?
Yeah, it does. I think that the kind of root question is, or maybe just a general clinical concern, is that right now we have limited ability to get like a baseline urine drug screen. So that's something that has to be negotiated with the client, the state of Maryland. So oftentimes we're in the position where we're relying on clinical objective symptoms, but a lot of it is history. And so if I kind of go in thinking, well, the vast majority of patients who present to us are probably have fentanyl among their use. If they're doing IV heroin or their nasal insufflation, I can probably assume there's going to be some fentanyl mixed in. Then, I want to kind of err on the side of caution, give a little bit more time before initiating, but not so much time that they're uncomfortable. And I've heard stories where people are waiting 48 hours and giving 2 milligram doses, and then an hour later they go for the 8 and the patient precipitates.
Yeah.
So that's kind of the space that I'm in navigating now.
So I would just throw out there that Eric Weintraub and Chris Welsh, two of the other doctors that are in our division, who are also Max consultants, they've been doing buprenorphine initiation and continuation via telemedicine at some of the correctional facilities in the Eastern Shore. And so that it probably would make sense to talk. I'm sure Max would be happy to set up a technical assistance meeting, Dr. McElry, so I'm sure we could help develop some protocols, for your setting that would work with the resources that you have.
Thank you. I appreciate that. Thank you.
Yeah, I can't wait you're here in Baltimore?
Yeah. So I serve Baltimore Central Booking and Intake, MTC, and MCIW. For it's 3 sites, and we're about to kick off House Bill 116.
Exciting.
Yeah.
Love to hear more about it.
Yeah, looking forward. Thank you.
All right, we don't have any other questions right now. If any questions come to mind after today's training, please contact Max, and we are always here to help. I just put our contact information into the chat. Other than that, thank you so much for spending a couple extra minutes with us, and thank you to our great presenters today, Dr. Greenblatt and Dr. Gandhi. Once again, just look out for an email with the slides as well as the survey that will pop up in a browser once you leave this window. If for any reason it does not pop up, you will be contacted directly from email. Thank you all for joining. Please feel free to log off and just look out for those other resources.
Bye, everyone.